Hi, I'm Anne Woolfield.
I'm Mel Akerman.
And I'm Carla Pecoraro, and we're your hosts of the Uterine Sound podcast, bringing you up-to-date information in all things O&G. This week, we're covering Intrahepatic Cholestasis of Pregnancy, formerly known as Obstetric Cholestasis. So firstly, let's get into this name change. Surely Obstetric Cholestasis and Intrahepatic Cholestasis of Pregnancy mean the exact same thing. Why go to the hassle of changing the name to something more complicated?
So although we do use the terms obstetric cholestasis and intrahepatic cholestasis of pregnancy interchangeably, ICP is the preferred terminology. Intrahepatic cholestasis of pregnancy is thought to more accurately reflect the pathophysiology of the condition, being altered transport of the bile acids within the liver. This slowing or stasis of bile acid transport results in accumulation of bile acids in the bloodstream, which then deposit in the skin causing itch or cross the placenta and affect the baby, leading to stillbirth.
In Australia, the incidence of ICP is about 0.6 to 0.7% of pregnancies. But we do notice that there is some ethnic variation. The incidence tends to be a bit higher in Indian and Pakistani women, with a rate of 1 to 1.5%. And there is one subpopulation called the Araucarian Indians of Chile who have the world's highest rate of ICP at a whopping 27.6%.
Wow, there you go. Now, the pathogenesis of ICP, like most things in O&G, is poorly understood. It's thought to be due to a combination of genetic susceptibility, hormonal factors, and environmental triggers. So, genetically, we've seen that there's ethnic variation. Clearly, there's something in the genes of different ethnicities that is contributing. We know that there are certain genes implicated in the condition, for example, rare genetic variants of bile acid transporters, like the ACB4A gene mutation, among several others. We tend to get clustering in families, so if your mother or sister has had ICP, then you're more likely to develop it as well. And we know that there is a high recurrence rate. So all of these things suggest that there is some element of genetic susceptibility. Then we move on to hormonal factors. There tends to be an association with elevated estrogen levels. Women appear to develop ICP around the time that the estrogen levels are highest, in the first trimester after OHSS, in the late second trimester, and in multiple pregnancies, all times where the estrogen level is increased. And there's also the association of cholestasis in women on the combined oral contraceptive pill. Finally, we need to consider our environmental factors. Low dietary selenium and low vitamin D levels have been associated with an increased risk of ICP. There's also a higher incidence of ICP in the winter months in countries like Sweden, Finland, and Chile.
So, Carla, you mentioned that hormonal factors are a big contributor to the development of ICP. Is there any association with progesterone at all?
Well, actually, there is some emerging evidence that alterations in progesterone metabolism may also play a role in the pathogenesis of ICP. In some women, the formation of large amounts of sulfated progesterone metabolites might result in saturation of the hepatic biliary transport system. These sulfated progesterone metabolites have also been associated with pruritus and are actually thought to be more related to the development of itch in ICP than bile acids.
If you actually look at the package insert for hydroxyprogesterone caproate, which is an intramuscular progesterone that used to be used for the prevention of preterm labour, it actually describes an 8% incidence of pruritus in treated patients and lists cholestatic jaundice of pregnancy as a contraindication to therapy.
Does this mean we should be avoiding exogenous progesterone in women at risk of ICP?
So absolutely not. There is no evidence that progesterone supplementation for the prevention of preterm birth actually increases the risk of ICP.
Okay, so who exactly is at risk of ICP?
Women who are at increased risk of ICP include those with a personal or family history of ICP, women with advanced maternal age, those with hepatitis C infection, and multi-fetal gestation. We know that there is a 20% incidence of ICP in twins and a 43% incidence in triplets, which is really high.
And how does ICP present in patients?
Women will typically present with pruritus, which is just a more difficult way to pronounce itch. The pruritus is typically described as starting on the palms and soles, but if you actually look at studies that talk about the distribution of itch in women who have cholestasis, it can be anywhere. It can be itchy eyes, it can be itchy ears, breasts, abdomen, back, basically anywhere in the body. So we generally say if there is any itch, then you need to be considering ICP. The severity of the itch can range from mild to incredibly severe and can have quite a significant impact on the woman's quality of life. Now, it's not associated with a rash. Now, this is really important. If you see a rash associated with the itch, it's very unlikely to be cholestasis. Obviously, those conditions can coexist, but that's pretty uncommon, so you should be thinking about an alternative diagnosis. Now, that's not to say that there aren't any skin changes with ICP. Obviously, if you've got an itch, you're going to scratch, and that's going to lead to scratch marks, excoriations, and even pruritic nodules. So if you are seeing some skin changes, take note of whether you think it's a rash or just some skin changes from scratching. We also notice that women tend to complain that the itch is worse at night. It typically develops in the late second or third trimester, most commonly after 28 weeks gestation, although we do occasionally get a case that presents before that. In about 5% of cases, the itch can develop in the first trimester, and this is typically around the 8-week mark and often associated with OHSS. And most importantly, the itch resolves rapidly after delivery, usually in the first couple of days. So that's the first thing we need. We need pruritus. But itch is not enough. Itching occurs in about 23% of women, but as we said before, the incidence of ICP is only 0.6 to 0.7%, so itch alone is not enough to diagnose ICP.
And for diagnosis, that's where the total serum bile acids come in. What we're looking at here is this peak bile acid concentration that occurs at any point throughout a woman's pregnancy. Interestingly, the degree of itch is not correlated with the bile acid level. So you could have a really severe bile acid level, but the itch isn't that bad, or very low bile acid levels and a really severe itch. There are some emerging studies that itch may be more related to those breakdown products of progesterone rather than the bile acids themselves. So ongoing studies and treatments are looking into this pathway. It's also really good to know that itch might occur before the onset of abnormal bile acids. Now, this is really important because if you've got a woman who has an itch and you do the bile acids and they are not elevated, you might think, great, it's not ICP, wash your hands and move on. Well, no, that's not what we should be doing. What we should be doing with a persistent itch is repeating the bile acids fortnightly or weekly because the onset of elevated bile acids can actually occur as late as 15 weeks after the onset of itch. So it's important that we continually monitoring in order to detect that point at which we can actually diagnose ICP.
And what is the bile acid cutoff for the diagnosis of ICP?
A diagnosis of ICP can be made in the presence of pruritus and an elevated non-fasting bile acids of 19 or more.
Wait, 19? Hang on a minute. I thought we could diagnose ICP if the bile acids were 10. And what happened to needing to have fasting bile acids? I remember having to send my patients home and getting them to come back the next day fasted just so they could get the bile acids done. When did this all change?
You are absolutely right, Carla. We did used to diagnose ICP on the basis of itch and fasting bile acids greater than 10. We've since realized that what we should be actually looking at is the highest bile acid concentration that occurs at any point during pregnancy. And bile acid concentrations actually peak after eating. Because of this, women are now advised not to fast before their bile acid test. In fact, the best time to have your bile acids tested is 30 to 120 minutes after eating. Actually, the highest levels are usually detected after lunchtime. So if you were going for the absolute optimal time of collection, it would be an hour or so after lunch. In reality, scheduling for that particular time of day is not very practical, and so we don't typically give women such strict timeframes. Fasting bile acids are more specific for the diagnosis of ICP, meaning if you've got raised fasting bile acids, then it's pretty convincing that you've got ICP. But they do have a lower sensitivity for mild disease. In one study, fasting measurements identified 9% of women with ICP, whereas non-fasting measurements detected over 91% of patients with ICP.
Okay. I guess that does make sense. But what about the cutoff? Why is it that it's now 19 and not 10?
The change in the bile acid cutoff has actually happened for a couple of reasons. Firstly, there was a population study of about 560 women that aimed to determine a pregnancy-specific reference range for non-fasting bile acids. The study found that the upper limit of normal non-fasting bile acids is 18 micromoles per litre. Secondly, there are no increased adverse pregnancy outcomes, such as preterm birth or stillbirth, in women with itch and total serum bile acids of under 19. Now, it's important to realize that there is no real diagnostic test for ICP. There's no direct test which we can do that says, yes, you definitely have ICP. We've got this test, can prove it. Instead, we treat ICP more like a syndrome. The main reason we worry about ICP is because of the adverse perinatal outcomes, the risk of preterm birth or the risk of stillbirth. Since studies have shown no increased risk to the fetus with bile acids under 19, there's probably no point in us giving these women a diagnosis of ICP. They're much better being off simply managed as gestational pruritus. By taking a non-fasting upper limit of normal of 19 micromoles per litre, almost 20% of women previously considered to have ICP don't actually have this diagnosis.
Okay, so let me get this straight. If a patient has pruritus and bile acids less than 19, they have gestational pruritus. If they have itch and bile acids of 19 to 39, they have mild ICP. Itch and bile acids of 40 to 99 is severe ICP, and itch and bile acids over 100 is very severe ICP. Are there any other features of ICP we should be aware of?
Women with ICP might also describe insomnia, malaise, excoriations, dark urine, and jaundice. Jaundice occurs in about 14 to 25% of patients and typically occurs a few weeks after the onset of itching. There can also be steatorrhea, which is also quite rare. In terms of investigations, there can obviously be deranged liver function test. Serum transaminases are increased in about 60% of cases. Usually they sit at less than double the upper limit of normal, although they have been known to reach levels of greater than 1,000. We can also see raised levels of bilirubin, although the total bilirubin rarely exceeds 6 milligrams per deciliter.
Okay, so this raises yet another question. Didn't we used to be able to make a diagnosis of ICP with either elevated bile acids or elevated transaminases? Can we still use deranged LFTs alone to diagnose ICP?
In short, no.
Okay, that is certainly the short answer.
Previous guidelines suggested that the diagnosis of ICP could be made with an itch and deranged LFTs or bile acids. This has definitely changed. As we research more and more into this condition, it turns out that the level of deranged LFTs does not correlate with any adverse fetal outcomes. Only the raised total serum bile acids are associated with the risk of stillbirth. Since the whole point of diagnosing ICP is to identify those at increased risk of adverse pregnancy outcomes, there's not really any point in diagnosing women with an itch and deranged LFTs as cholestasis. Itch and elevated transaminases alone does not equal a diagnosis of ICP. You need to have raised total serum bile acids.
Okay, fair enough. So let's do a quick summary of what we've learned so far. Intrahepatic cholestasis of pregnancy is a pregnancy-specific liver disease diagnosed by pruritus and a raised total serum bile acids of 19 or above. Mild ICP is when the bile acids are 19 to 39. Severe ICP is when the bile acids are 40 to 99. And very severe ICP is when the bile acids are 100 or more. ICP occurs in 0.6 to 0.7% of pregnancies in Australia, and it typically occurs after 28 weeks, although 5% of cases can occur earlier, usually in the first trimester, and it's usually associated with OHSS. Risk factors include a personal or family history of ICP, advanced maternal age, multiple gestation, and hepatitis C infections. The pathophysiology is unknown, but it's thought to be due to a combination of genetics, high estrogen levels, and environmental factors.
So the other thing to think about here is that ICP is supposed to be a diagnosis of exclusion. We actually don't have a clear diagnostic test that says, oh look, yes, I can see the bile acid in your liver is slowing and this tells me that, and you therefore definitely have ICP. Instead, what we say is, okay, you have itch with these elevated bile acids. We know that this level of bile acids is associated with increased risk in your pregnancy, and therefore we're going to label you as ICP and take steps to reduce those risks. Previous guidelines recommend that ICP is a diagnosis of exclusion and that routine tests should be done to exclude other causes for the clinical picture of ICP. This included doing routine viral screens, liver ultrasound, and testing for autoimmune hepatitis. A recent retrospective review of over 500 pregnant women with raised bile acid concentrations suggests that the likelihood of identifying a viral, autoimmune, or structural cause for the itching and liver derangement that was not suspected on other clinical grounds is extremely low. So it turns out we were just spending a lot of money on tests that weren't picking anything up. They were very low-yield investigations. For this reason, the current guidelines state that routine use of other investigations is no longer recommended.
That doesn't mean we should never do additional investigations, though. What we want to do is assess the clinical history, arrange targeted investigations, depending on what we find. The features that might prompt you to do additional testing would be markedly elevated transaminases, early onset of ICP in the first or second trimester, rapidly progressing biochemical picture, any features of liver failure, evidence of acute infection, or if it doesn't resolve after birth.
Okay, so what exactly are the tests we should be ordering if we are going to order some?
So, we usually recommend performing hepatitis A, B, and C serology and EBV and CMV serology in anyone with a clinical suspicion of viral infection. Then we're looking for autoimmune hepatitis. AMA, anti-smooth muscle antibodies, and anti-liver kidney microsomal antibodies should be considered in women with bile acids over 40, in those with ICP below 30 weeks, if the transaminases are over 200, or if they have a family history of autoimmune disorders. A liver ultrasound should be performed if there are any concerns for any structural causes, although keep in mind that gallstones are more prevalent in patients with ICP, and so an ultrasound finding of cholelithiasis does not always mean that this is the cause of itch and deranged LFTs. Coag studies are not recommended routinely for pregnant women with uncomplicated ICP, but should be considered on an individual basis, especially when failure of liver synthetic function or failure of fat absorption is suspected, for example, in those patients with steatorrhea. SOMANS recommends coags at the time of diagnosis if the bile acids are over 40, and again prior to elective birth. If the INR is over 1.4 or the APTT is over 40 seconds, then 10 milligrams of IV vitamin K should be given and the coags should be assessed weekly.
So why do we care about obstetric cholestasis? We've alluded to this before. You've got itch and raised bile acids. We call this intrahepatic cholestasis because it's associated with an increased risk of complications. Well, what exactly are those complications? What are the risks to mum?
Well, clearly there's the pruritus. Now, as we've said before, this can be incredibly severe and very debilitating. People with severe itch actually have an increased risk of suicide, or they might request early induction because their symptoms are so severe. It's very crippling and quite difficult to deal with. There are also increased risk of gestational diabetes, a 3 times increased risk, and a 10 times increased risk of preeclampsia. We're still doing further studies into this, but the pathogenesis of GDM, preeclampsia, and ICP are thought to be somehow interrelated. Women with ICP are also at an increased risk of vitamin K deficiency, particularly those with steatorrhea and fat malabsorption, and as a result, they may have an increased risk of postpartum hemorrhage. ICP is also thought to affect women in the long term, causing an increased risk of chronic liver disease. There's also an association with gallstones, liver and biliary tree cancer, diabetes, thyroid disease, psoriasis, inflammatory polyarthropathies, and Crohn's disease. The overall incidence of the majority of these conditions with ICP is less than 1%. So it's really quite low, but it's certainly something to think about, and it's why we'd recommend annual liver screening in someone with ICP.
Now, the complications to the mum are not as significant as the complications to the baby, and the fetal complications are really the crux of why we worry about ICP. So in the baby, the biggest risk we worry about is stillbirth. But babies can also have meconium liquor. They are at an increased risk of preterm birth, both iatrogenic and spontaneous. They have an increased risk of neonatal respiratory distress syndrome, and that's thought to be due to the bile acids causing direct toxicity to the lungs. We're not really sure how these babies are affected long term. We don't really have any good data on this yet, but it's worth keeping an eye out to see if there are any long-term risks of fetal complications with ICP.
So let's dive a bit deeper into stillbirth, the main reason we worry about intrahepatic cholestasis of pregnancy. What's thought to happen with this is that the maternal bile acids cross the placenta and they accumulate in the fetus and the amniotic fluid. And these bile acids are toxic. They are toxic to fetal cardiomyocytes. The cause of death is thought to be related to the sudden development of fetal arrhythmia. There is actually evidence for this in rat studies. What they did was they cultured rat cardiomyocytes and they dropped bile acid onto these myocytes. And what they saw was that the heart would just start to beat slower and slower, and then it would go irregular, and then it would just stop. And so that is one of the proposed theories for why we get sudden stillbirth in ICP, a sudden onset of a fetal arrhythmia. There's also a theory that bile acids cause sudden vasospasm of chorionic surface vessels in the placenta. And then there's a theory that the risk of stillbirth might be related to the other conditions that have increased rates in ICP, like GDM or preeclampsia, for example.
We also know that the risk of stillbirth increases as the concentration of bile acids increase, and it tends to be associated with the highest level of bile acids at any point during the pregnancy. The risk of stillbirth also increases with gestational age. Our data for the risk of stillbirth comes from a study published in The Lancet in 2019. If you've got mild ICP with a bile acids of less than 40, then the risk of stillbirth is 0.13%, which is not increased above the general population. So these women can be reassured that there's no increased risk of stillbirth. If you've got severe ICP with bile acids of 40 to 99, the risk of stillbirth is 0.28%. Now again, this is not significantly increased above the general population until you get to 38 to 40 weeks gestation. But if you've got very severe ICP with bile acids of 100 or more, then the risk of stillbirth is 3.44%, and it increases rapidly from 36 weeks gestation.
The other major complication of ICP is preterm birth. Women with ICP have an increased risk of both iatrogenic and spontaneous preterm birth. So, iatrogenic preterm birth is when we induce delivery because we're worried about the risk of stillbirth or because of intractable itch. But interestingly, the risk of spontaneous preterm birth is also increased. Bile acids appear to increase the expression of myometrial oxytocin receptors, which may explain the increase in preterm labour and spontaneous preterm birth. Pregnancies complicated by spontaneous preterm birth also appear to have a much earlier onset of pruritus. Now, we said before that the risk of stillbirth is not increased with bile acids under 40, but the risk of preterm birth is. With mild ICP and bile acids less than 40, the risk of preterm birth is 10 to 16%. With severe ICP and bile acids of 40 to 99, the risk of preterm birth is about 20%. And with very severe ICP and bile acids of more than 100, the risk of preterm birth is 30 to 35%.
So this brings us on to treatment. What can we do to manage ICP? Well, our two treatment goals are to reduce bothersome symptoms and to reduce the risk of perinatal morbidity and mortality. So the first thing women want to know is, how can I stop itching? This is driving me crazy. Somebody please help. So what can we do for itch?
We usually advise women to try and break the itch-scratch cycle. Avoiding hot showers, scratching, and rubbing is a must. Cool compresses can be quite helpful in suppressing itch. So I usually suggest women keep a wet washer in the fridge and try that instead of scratching. Sodium bicarbonate baths can also be quite soothing. Then we've got antihistamines. Our typical regime is cetirizine, 10 milligrams once to twice a day, although you can also use loratadine. Then promethazine or phenergan, 25 milligrams at night. This has a sedating effect. It can really help women sleep. Finally, we use topical emollients. For example, plain moisturizing lotion like Sorboline, liquid paraffin, pine tar solution, aqueous cream with menthol, or calamine lotion. Now, urso. When we think ICP, we think urso. What is it and how does it help?
So, ursodeoxycholic acid is actually a bile acid. Now, I know, that seems counterintuitive. It makes no sense. Firstly, we're saying the elevated bile acids are the problem, and now we're saying we want to give more bile acids. How does that make any sense? Well, urso is actually a good bile acid. It works by replacing the more toxic hydrophobic bile acids in the circulating bile acid pool. Now, it does actually contribute to the total bile acid level, but it does that by increasing the good bile acids and decreasing the toxic bile acids, essentially diluting the toxic bile acids. Urso improves biliary blood flow, it enhances the protective bicarbonate environment on the surface of cholangiocytes, and it's actually been shown in vitro to protect cardiomyocytes. Remember before when Mel said that they were doing the rat studies and they had the cultured rat cardiomyocytes and dropped the bile acids onto them to show how they cause arrhythmia? Well, if you drop urso onto those cardiomyocytes before the heart stops completely, You can actually restore a normal cardiac rhythm. Pretty impressive, right? So, how does that translate into the clinical effect of URSO in humans?
Well, unfortunately, the data for URSO is not that great. The largest study we have to date is the PICTURES trial. This was a randomized controlled trial of about 600 women aimed at investigating the effectiveness of URSO in treating ICP. Unfortunately, the trial found that URSO made no difference to the rate of stillbirth, preterm birth, neonatal death, or NICU admission, although there was a statistically significant reduction in itch. Now, here's the key word, statistically significant. Now, that doesn't equate to clinically significant. In the PICTURES trial, itch was assessed on a scale of 0 to 100 millimeters. Participants in the URSO group reported a reduction in itch of about 5.7 millimeters. So although this was a statistically significant reduction, it doesn't really translate to a clinically significant reduction in itch. The PICTURES trial also demonstrated that URSO did not improve liver transaminases or bile acids, and that these parameters tended to reduce naturally over the course of ICP anyway. The authors concluded that the use of URSO should be reconsidered because it does not seem to have any significant clinical benefit when used routinely for the treatment of women with ICP.
Since the PICTURES trial in 2019, there's been a meta-analysis demonstrating that URSO may reduce the risk of spontaneous preterm birth in women with ICP and bile acids of 40 to 99, but not greater than 100. There's also been a Cochrane review on pharmacological interventions for treating ICP. This found that URSO probably reduces itching, but the effect may not be worthwhile. URSO also does not reduce adverse perinatal outcomes of ICP. However, there was no other treatment options available currently.
Moving forward, there is currently an Australian trial underway called the Terrific trial. This trial is looking into the effect of rifampicin compared to URSO in the treatment of ICP. Rifampicin is a semi-synthetic antibiotic that reduces serum bile acids in the management of cholestasis in non-pregnant patients. It's currently used in ICP in the UK as an adjunct to URSO, but only under the guidance of a hepatologist. Keep an eye out for the results of this trial in the near future.
Okay, so we've spoken about management of itch and the role of URSO. Next, we need to discuss monitoring the pregnancy. Bile acid concentrations can vary, and as we said before, what we are looking for is the peak bile acid concentration. Bile acids should be assessed weekly to fortnightly depending on the started bile acid level. Once the bile acids reach 100, there's not really any value in further testing. The patient has now reached very severe ICP and should be treated as this regardless of whether the bile acids drop. It's very important that we don't revise the severity category just because the bile acids have improved. Now, being a bile acid, URSO itself can actually contribute to the assay of total serum bile acids. If the patient is on URSO, blood should ideally be collected for bile acids shortly before the next dose, because URSO can contribute up to 60% of the total serum bile acids.
There is no value in monitoring the baby with serial growth ultrasounds and CTGs, unless there are other indications like decreased fetal movements. ICP is not typically associated with oligohydramnios or fetal growth restriction, and as we said before, the mechanism of death is thought to be a sudden event rather than as a result of chronic placenta vascular process. Therefore, growth ultrasounds and CTGs are not useful in the management of women with ICP.
Timing of delivery is probably the most important thing we can do for women with ICP to reduce the risk of stillbirth. Delivery planning is based on the highest total bile acid level at any point during the pregnancy, maternal obstetric history, and symptoms. Women with ICP and bile acids less than 40 do not have an increased risk of stillbirth beyond the general population, and so they can be managed routinely. Women with severe ICP and bile acids of 40 to 99 do not have an increased risk of stillbirth until 38 weeks. From this gestation, the rate of stillbirth increases slightly, and so delivery is typically recommended from 38 weeks. Women with very severe ICP have a dramatic increase in the risk of stillbirth from about 36 weeks to as high as 1.5%. Because of this, delivery for very severe ICP is recommended at 36 weeks gestation. In some cases, you might even consider delivery before 36 weeks. This might include women with worsening hepatic function, women with excruciating and unremitting pruritus, and women with a history of stillbirth before 36 weeks due to ICP, with a diagnosis of ICP in this current pregnancy.
Postpartum, we would discontinue urso if the patient has been taking it. The itch tends to disappear within 1 to 2 days, and jaundice typically resolves within a week. The total serum bile acids normalize within 1 week, although we do recommend they get checked with the liver function test at 6 weeks. Any persistent abnormality at this stage should be followed up with additional investigations and a referral to a hepatologist. Annual liver function tests should be considered because of the increased risk of chronic liver disease, and women should be counselled on the risk of recurrence in the next pregnancy, which is about 60 to 80%.
We also need to talk a little about contraception, my favourite topic. We used to recommend that women with ICP avoid estrogen-containing contraceptives because they can result in recurrent cholestasis. But actually, the COCP can be started once the LFTs have normalised. Patients should be informed for the possible development of pruritus or cholestasis and have the LFTs monitored 3 to 6 months after starting the OCP. If they develop an itch or deranged LFTs, then obviously the OCP should be stopped and they should have further investigations.
Now, before we wrap up, I just want to point out an amazing resource that we hadn't heard about until writing this episode. It's called ICP Support, and it's a UK-based website that is useful for both clinicians and patients worldwide. This support page was started by an incredible lady named Jenny Chambers, who herself experienced stillbirth in the context of ICP, well before ICP was recognised as a common clinical entity. This woman is amazing and has been instrumental in progressing our understanding of ICP. She was one of the first people to trial URSO for ICP and is actually a co-author in the Pictures trial. The resources available on this page are fabulous, and it also contains a lovely summary of the available literature on the topic. We highly recommend it.
Thanks for listening to this week's episode of the Uterine Sound podcast. You can find our summary slides on Instagram later in the week. If you have any comments, feedback, or want to fact check us, please reach out on our email, theuterinesound@gmail.com. You can also catch us on Instagram and Facebook at The Uterine Sound and our website, www.theuterinesound.com.